Hey everyone, and welcome to this lecture on chapter 19. So this will be our last lecture for this course. Nice job, you made it here. So as we were talking in chapter 17, 17 and 18, this is just the kind of the last conversation about nutrition throughout the life cycle. So in chapter 19, we're going to talk about nutrition. We kind of skip over adulthood, as I think I mentioned in the chapter 18 lecture, because so much of what we already talked about in units 1 through 4 effectively apply to adult nutrition. So here we move to like older adults and elderly and kind of end of life. So in this age category, we're talking about roughly age 65 and older. We might call that older adults, or people in that age group, we might call them older adults. And then anyone who's 85 years or older, we might call them elderly or even very elderly, kind of the oldest subset of the population. And interestingly, at this point in time, in this 21st century here, the very elderly subpopulation is actually the fastest growing subgroup within the total US population. In this part of the lifespan, we can talk about life expectancy and lifespan. So lifespan is defined as the age to which the longest living member of the species has lived. So it's sort of like how long an individual or an organism in this species could possibly live. Like we talk about sea turtles, I feel like we say that the lifespan of a sea turtle is 150 years. I don't know if that's exactly correct, but or we say the lifespan of a lot of songbirds is actually only 4 or 5 years. So that's just referring to the age to which the longest living member has lived. And then life expectancy is the average age of death, basically, for organisms or for individuals within that species. So for females, the average life expectancy, and this is based on data just within the United States, is about 81 years old. And for males, it's about 76 years old. Now, again, that's just average. So obviously, some people will live quite a bit longer than that, and some people will live not quite as long as that. This is just a chart showing again, let me toggle back here, showing kind of that the very elderly is kind of a rapidly growing subpopulation within the United States. So this is showing data from 1960, age ranges and the number of millions of people, male and female, in these age groups. And so you can see in the 1960s, actually probably the smallest subset of the population was 85 and older. And now we're projecting in 2060, that's going to be, at least for females, one of the major population subgroups. So when we talk about aging, as we've done at various stages in this course, we can talk about some of the theories as to how aging occurs. So there's 2 sort of categories of theories of aging, and this shows up in one of your lab questions. So take a second to kind of understand the difference between error theories and programmed theories of aging. And I'll just toggle ahead. This is table 19.1 from your book. It spans 2 pages here in the lecture. But this is just showing that there are actually 4 different types of error theories of aging. And there are 4 different types of programmed theories of aging, or 4 different theories within these categories. So just make note of that for yourself for the lab. So aging, first and foremost, we can define as basically changing that occurs at the changes, I suppose, and sometimes deterioration or loss of function that occurs at the molecular level, the cellular level, and then the level of tissue or organ. So we just see basically declining in functioning, sometimes decline in structural integrity. So in programmed theories of aging, these theories are going to suggest, and again, these are theories, so like ways of thinking. We haven't necessarily proven these to be true. But programmed theories of aging suggest that aging follows a biological timeline, very similar to what we actually just discussed from infancy through childhood through adolescence, that there are kind of biological markers, chronological markers of this aging process. So we'll look at a few examples on the next slide. And then by contrast, error theories of aging suggest that aging occurs as a result of errors, basically. Errors that have occurred throughout an individual's lifetime that have caused the cellular, molecular, and tissue damage. A lot of this we actually did talk about. So we talked about, I guess the big one we talked about was oxidative stress. So we learned about free radicals, we learned about exposure to different toxins, and basically in error theories of aging, the line of thinking goes, the more exposure to free radical damage, especially without the protective functioning of antioxidants and anti-inflammatory compounds, the faster or the more, maybe the earlier the onset of the aging process. Other examples in this theory or other concepts in this theory would be that, maybe there is some natural decline in function, but as that decline occurs, one of the things we'll see like at the cellular level, so if the cell membrane starts to decline in its function or its integrity, then maybe we actually see like waste accumulation inside of the cell. Maybe we see some of that accumulating around the cell membrane or even in the cell membrane. So that can lead to, decreased ability for those cells to take in nutrients. And that would in time lead to obviously damage to that cell. And maybe that starts to infect some neighboring cells and so ultimately lead to damage of that total tissue. And then we can also see, and I think this is kind of, these last two pieces are really interesting parts of this theory, just changes in our protein. So DNA repair, we didn't really talk much about this. We don't talk much about this in this class, but we can see free radical or oxidative damage at the level of DNA. And so if the DNA is damaged due to oxidative stress, and again, there aren't enough antioxidants or anti-inflammatory compounds to repair that DNA damage, that's going to lead to faulty protein production. So, and then protein production, proteins are so much of what make our bodies, what regulate our bodies. So if all of a sudden, or not all of a sudden, but if over time, due to damage to the DNA, we're making abnormal proteins or proteins that are non-functional, then of course we're going to see loss of function throughout the body, or potentially in one particular part of the body. And in a similar fashion, this idea of glycosylation, this is the process of a glucose attaching to a protein when it shouldn't really or wouldn't normally. And that can also change the nature of the protein, so it changes the function of the protein. And so that can be part of the aging process. So you don't need to memorize any of these theories, but just recognize that there are two overarching categories of theories of aging. So there's programmed theories of aging and there's the error theories. If you want to, for sure, take some time and look through some of these suggested descriptions. Also look through how nutrition may either play a role in or could potentially be reversing the aging process. So I'll highlight, I guess, the theory of programmed longevity. So this theory suggests that aging occurs when certain genes are turned on or off, and that the activation or suppression of these genes would then trigger the loss of function. So again, as I kind of said a bit on the previous slide, diet rich in antioxidants, especially vitamin C and E, could potentially lower free radical damage to DNA, which would more likely not turn genes on that trigger age-related loss of function. So you'll notice kind of that theme. These antioxidant-rich foods are really important, not just, not just when we're talking about being a healthy 20-something or healthy 30-something, but they're really important like day in and day out throughout the lifetime to counteract the inevitable exposure to oxidative stress. And so the more consistently, I suppose, throughout a person's lifetime that person consumes antioxidant-rich foods, more likely the better their health will be in aging, and perhaps the more slowly the aging process would come on for that person. And then in error theories of aging, again, there's a lot of overlap here, right? Like there's the free radical theory here, which again would suggest that this concept of senescence or cell death is due to the cumulative damage caused by free radical exposure. So then again, a diet rich in antioxidants, again, vitamin C and E, selenium, the phytochemicals that we learned about may actually wind up limiting cellular accumulation of free radicals. So take a look at this. Here's where glycosylation shows up. Lots of, I think, really interesting stuff. Again, what I'm asking you to do is at least just make note of the two overarching theories and their concepts. So let's talk a bit about the aging process and what we see there. Biological age is a term to know. So biological age is just referring to the physiologic state of the body. So physiology meaning, you know, we're talking about all those inner workings of the body, a lot of what we've learned about, but all the different systems like your cardiovascular system, your bone health and the bone remodeling that goes on throughout the lifespan. We're talking about vision, we're talking about the musculoskeletal system, we're talking about the liver, the digestive system, the kidneys, we're talking about the brain. So biological age is just saying that the physiologic processes of all of these different body systems can age in time. And as those systems age, the body is aging. So biological age rather than chronological age is referring to how old, I'll say, how old those systems appear to be based on their health and functional status. Whereas chronological age is referring literally just to years. I think maybe an easy example to understand this difference is like, say you have two people in their 50s. One person has been overweight or obese since their early adolescence. Maybe they've been smoking cigarettes since their early adolescence. Maybe they eat kind of the meat and potatoes type of diet or the standard American diet, which is, again, you know, fast food, a lot of French fries, maybe a lot of candy, maybe drinks a lot of soda. So let's say that's person one, person A, and then person B maybe is also again 50 years old, but let's say, you know, they've been moderately active their whole life, like to ride the bike, like to go for walks, like to go on hikes on the weekends, never smoked cigarettes, always had a, you know, roughly healthy weight, maybe a little overweight sometimes, and eats a pretty healthy diet, lots of fresh fruits and vegetables, not a lot of fast food, no soda, plenty of water. So those two people have the same chronological age, but person B with the healthy lifestyle is probably going to have a younger biological age compared to person A. And all that's saying is that if we were to look at the physiologic healthfulness of the body, person B appears to have like younger, more robust, more well-functioning organ systems relative to person A. Where person A, if we just looked at their organ systems, including their skin, right? The skin is an organ, including their eyes, just whether the eyes look vibrant and, you know, supple and hydrated, or whether they look kind of sunken in and dry. We can see sometimes biological age and physiological age. So even though chronologically they're both 50, person A, you know, maybe physiologically their organs reflect that of a 75-year-old chronologically aged person. So that's the that's kind of the difference between biological age and chronological age. And so as that example, I know that's a verbal example, I should include a picture here, but as that example described, I didn't mention alcohol, but right, that would be another factor that could influence biological age or physiologic age. So all the things we've talked about, right? Smoking, and it's not listed here, but a poor diet, right? An unhealthy diet, excessive exposure to UV radiation, again, obesity, and lack of physical activity. All of these would basically cause a person's biological age to effectively pass more quickly than their true chronological age. So senescence, this word showed up on that table 19.1 chart. This is basically programmed cell death. So over time, cells basically do lose function. They can lose some of their structure. And so as that happens, there comes a point where the cell effectively dies and is no longer functional. And so if that happens to the majority of cells in a given organ system, well, that's going to result in either disability of that organ system, definitely disease of that organ system, and eventually like non-function of that organ system. So a lot of what we'll talk about in this chapter relates to this idea of cellular senescence, this progressive deterioration of the organs and the organ systems. So I think actually I have several examples of this just on this slide and maybe the next one. So what these two slides are going to look at is change in sensory perception, or at least on this slide we're going to. So as we age, our sensory ability, so our ability to sense smells and tastes, and even our ability to see well, all do decline with age. And so again, that is due to the process of senescence. So due to the process of this just slow progressive deterioration of, the functioning of the tongue, the functioning of the taste buds, the functioning of the olfactory receptors, the functioning of the eye, the retina, the cornea, those rods and cones that we talked about. So one example of an actual like change in the physiology is what we call dysgeusia, which is an abnormal taste perception. So no longer tasting things either as fully, or maybe they just don't taste the same way that they used to. Again, we would see loss of visual acuity, so difficulty seeing objects far away, potentially also difficulty seeing things close up. So certainly family and friends can support older adults with food selection and food preparation techniques as they may begin to lose their sense of taste and smell. So in the same way, we're going to see this senescence occurring in the gastrointestinal tract. So some of the changes that would be not uncommon to see in older adults and very elderly people would be xerostomia, which is a decline in production of saliva. We would see dysphagia, which is that difficulty swallowing. We see achlorhydria, which is a pretty common occurrence. So there might be low hydrochloric acid production in the stomach. This is certainly going to interfere with the absorption of a few micronutrients. So the key ones to look out for are calcium, iron, folate, and B12. So if someone does have achlorhydria, there may be potential subsequent nutrient deficiencies in these 4 nutrients. Also, we do see some pretty significant changes to the gut microbiome. So the microorganisms that live in our gut do change as we age. What we see is we tend to see a decline in some of those healthy beneficial microbes. So that can lead to increased inflammation. It can certainly hinder the immune system as well, because as we talked about a little bit, the immune system kind of starts in the digestive tract, and the healthy beneficial gut microorganisms that live there help to stimulate our immune system. So we might see decreased immune functionality. We're also going to see those cells that line the intestines, so those enterocytes, those gut mucosal cells, they're going to be affected. Also the mucus cells, so the cells that actually secrete some of the mucus in the digestive organs, those are also going to be impaired. So all of this is just going to alter an older adult's digestive capacities. And any of this can come about simply just by aging, just by the life, by actually these processes of senescence. Some medications may actually speed up these changes in the gut microbiome. Of course, lifestyle and diet are going to affect these changes. Yeah, and other lifestyle factors too. Well, lifestyle diet, I guess what I mean there is like the diet over the lifespan, right? So what has this person eaten for most of their lifetime? You know, maybe they were kind of a burgers and fries and soda person all the way up until they were 70. And then maybe when they were 70, they decided to change and start having a healthier diet. But we need to consider that 70 years of their lifespan, they were consuming foods that were basically contributing to the poor health and disease of their gut. And then other lifestyle factors, so again, physical activity, smoking, alcohol consumption, those things. We also see what's called anorexia of aging. And so you might remember this term anorexia unto itself just literally means like a lack of an appetite or a lack of interest in eating. So we do see that more commonly in elderly adults. And it's basically expressed as just, you know, if and when they eat, they kind of get full from the food faster, and they're maybe hungry less frequently. So they're less frequently are they looking to go have a meal or looking to go eat something. So again, as we said actually back on this slide, family and friends and other support people become actually pretty important in this case to help make sure that the older adult is, or the very elderly adult is getting the right amount of food and good quality food too. Also, we see a pretty significant increase in lactose intolerance among older adults. So it's estimated that only about 30% of older adults actually maintain the ability to produce lactase, which is our enzyme to digest lactose, the sugar found in milk. Other digestive enzymes, it seems that as we age, we actually do produce, most older adults are going to produce enough digestive enzymes into their older adult years and even into their elderly years. Certainly, the older we get, maybe the less we're producing. But you know, into the 65-year-old, 75-year-old, there should still be a good amount of digestive enzyme production. The one that changes is lactase. So this would be certainly a good time in the life cycle to check in on dairy consumption and potentially curtail that, if not remove it altogether. And then we're going to see changes to body composition. Again, all of this relating back to cellular senescence. Some other definitions here. So sarcopenia. This is progressive loss of muscle mass that goes along with aging. So as muscle mass decreases, we're going to see reduction in muscular strength and, of course, reduction in muscular function. So I think, you know, any of us who have known someone to live into their 70s or 80s or even 90s, I think we see that pretty clearly, right? Just changes in their physical ability, changes in their physical strength. That's a natural part of the aging process. Not to say that any older adult or elderly adult can't be strong and can't be able-bodied, but certainly if we compared that person back to their 30-year-old self, even 40-year-old self, we would see some loss of muscle mass and strength. It's also not uncommon, well, it's normal to see an increase in body fat. So again, it doesn't have to be an excessive amount of fat, but it tends to be that as we age, we lose muscle mass at the, and kind of the trade-off, I guess, is we tend to gain a little bit more body fat. So anybody who like an older adult or an elderly adult who does have an excessive amount of body fat on them, who would be considered obese, and is experiencing this sarcopenia, we call that sarcopenic obesity. So having kind of this excess of body fat at the same time that this elderly person is experiencing the loss of muscle mass of aging. Of course, we see decreased hormonal production, so decreased testosterone, decreased estrogen and progesterone, decreased growth hormone. So all of that's contributing to less ability to build muscle mass, which is what leads to the loss, part of what leads to the loss of muscle mass. We also see that bone mineral density declines, of course. Fortunately, though, again, it's not to say that we just succumb to this, eventual loss, total loss of muscle mass. It's a progressive, it can be a slow progressive decline. And there's plenty that we can do as older adults and elderly adults to slow this decline quite a bit. Of course, it's the same things we've talked about all semester long: eating a healthy diet, getting regular physical activity that includes not just cardiovascular aerobic exercise, but also strength and resistance training, and removing any of these lifestyle factors or reducing any of these lifestyle factors that would further contribute to loss in bone mineral density or a decreased ability to maintain muscle mass or strength. So again, removing alcohol, reducing alcohol significantly, cessation of cigarette smoking, reducing even medications as much as is possible to maintain good health, or at least looking at medications that might be interfering with muscle strength and bone mineral density. We do have a chart coming up to take a look at medications and their effects on the body as we age. Again, we're going to see various declines in the function of different tissues and organs throughout the body. So in general, we could say that the organ systems of the body become less adaptable to environmental changes or stressors as we age. So the kidneys, they lose their ability or progressively lose their ability to concentrate waste products. So they're not functioning as efficiently. Again, another reason to really only put good things into the body, because any harmful substances or toxic material that come into the body, it's just going to take much longer for an older body to process these things out. The liver, same thing, less efficient at breaking down drugs. Pancreas, our ability to maintain glucose seems to decline as we age, especially females after menopause with the hormonal changes in estrogen and progesterone, especially estrogen. Bladder control, so the muscular control of the bladder also might decline. We see connective tissues and blood vessels, they lose their fluidity and their flexibility. And then the neurons in the brain, the total number actually decreases in time. So we see changes in memory, changes in reflex and coordination, and changes in cognitive abilities and learning. So perhaps not surprisingly, the total caloric requirements of an older adult or elderly adult does decline with age. And that's largely just due to this decrease in muscle mass, and also due to most older adults are just literally expending less energy throughout the day compared to, adults in their 40s or 50s or even early 60s. So as we're doing less, as we're less physically active, we're going to have a lower basal metabolic rate. We're going to require fewer calories to maintain the same weight. So it's estimated that total energy expenditure decreases about 10 kilocalories per year for males and about 7 kilocalories per year for female as we age. And I would say that's actually starting like in our 30s, even in our early, I'd say mid to late 20s is when this begins. And so it's just a slow, steady decline in the amount of calories that we need. Because obviously 10 kilocalories a year and 7 kilocalories a year, that's hardly noticeable, right? That's like a grape or maybe 3 grapes. So it's a really, really subtle decline. But if you take that over 30 years, that's 300 calories fewer that somebody in their 30s might need relative to somebody in their 60s. So over time, it does become significant. And then we see, of course, the decrease in energy needs can be delayed or minimized if we maintain, robust amounts of physical activity. Macronutrient shifts. So if total energy needs decrease, remember, where do we get energy from? We only get it from carbohydrates, fats, and proteins. Technically, we also get calories from alcohol, but we don't consider alcohol a macronutrient. So if our total energy needs decrease with aging, then our total macronutrients will also decrease with aging. The recommendations as far as the AMDR go will stay the same. So it's still going to be 45 to 65% calories from carbohydrate, 10 to 35% calories from protein, and that like 20 to 35% calories from fat. So the rough proportions stay the same, but again, that's based on, those are all percentages based on total calories. So if total calories is decreasing, then the actual amount of grams of fat, carbohydrate, or protein will decrease as well. After menopause for females, it is actually a good idea to increase protein a little bit. So maybe moving up more towards, 20% of total calorie intake, or 1.1, even 1.2 grams per kilogram body weight per day. I think this is also maybe one of the most important things in terms of healthy weight maintenance for females as we age, is really to take a good hard look at processed carbohydrate intake, especially flour-based foods, right? So anything that's made from a grain, but it's processed into a flour and then it's turned into bread or pasta or breakfast, like cold breakfast cereals, muffins or bagels or crackers or cookies or pancakes, the whole 9 yards. Those become really important to eat significantly less of, largely due to our decreased ability to manage blood glucose levels effectively. Also, older adults can eat slightly less fiber than the recommendation for adults. And again, that's due to the changing in the gut microbiome and just the other changes overall in the gastrointestinal system. So here's, I think, a cute little pictorial representation of a healthy eating plate and a healthy lifestyle for older adults and elderly adults. So certainly staying physically active, maintaining good hydration with water, really reducing dairy foods quite a bit, eating complex whole grain foods. Still half the daily intake would be fruits and vegetables, getting various sources of protein, and moderate amounts of helpful oils. Probably not margarine. I don't know why that's. Oh, that's kind of hilarious that that's on here. Margarine, you might remember, is one of our trans fat-rich foods. That's not one we want to be eating whatsoever. And then micronutrients. So how do our micronutrient needs change with aging? Again, we saw that if there's that decrease in the hydrochloric acid production in the stomach, we may need to take a close look at calcium intake as well as vitamin D intake. It tends to be that we will absorb calcium less well with aging. And again, just as senescence is implying this progressive decline in functioning of our systems, the skin becomes less effective in producing vitamin D, and the skin and the liver. And then our iron needs, interestingly, actually decrease. And maybe that's not so surprising as menstruation stops for females at menopause. We also see that reduction in muscle mass. So there'd be less need to carry oxygen to muscles if they're less big or smaller in size. The recommendation for zinc stays the same, as does the recommendation for vitamin C and E. Just remember, these are really important for a variety of reasons, one of which is antioxidant function. B12, B6, and folate, so all of these would increase a little bit above adult levels. And part of that is for the neurological functioning. So getting adequate B6, and again, adequate at this life stage, is a bit more than what we would take in for adulthood. That can help to slow dementia as well as depression. And even adults who are experiencing depression, it's worth a check of your B6 status. because B6 may actually help with depressive symptoms in adults. And again, B12, again, that atrophic gastritis, that decrease in hydrochloric acid production is going to interfere with B12 absorption. So definitely probably good to supplement with B12 or even consider the B12 injection if experiencing atrophic gastritis. Requirement for vitamin A would stay the same, but again, as we saw throughout adulthood, really important not to overconsume really any of our micronutrients. The only way to overconsume is through supplementation. With vitamin A, again, we already saw that this can be pretty toxic if we overconsume it as an adult, but now as an older adult or an elderly person, we have even less ability to, again, process out extra vitamin A. So the kidneys aren't functioning quite as well, so they're not going to be excreting the excess quite as effectively. So definitely be careful not to overconsume vitamin A. It can, as we saw with adults, it can lead to decreased functioning of the immune system, but it can also lead to increased risk for hip fracture, damage to the liver, and neurological problems. Okay, so this is just a nice overview of the nutrition recommendations that change in older adulthood. So increased need for vitamin D, up to 800 international units a day. Calcium goes up to 1,200 mg per day for females. And males over 70. And then again, the fiber need can decrease to about 30 for males 51 and older, and can even decrease to about 21 grams per day for females 51 and older. Again, B6 would go up, and B12 would be one to take a good look at. Let's see, decreased iron needs. Yep. So just kind of giving you the actual RDAs for each of these nutrients. So supplementation, yes, supplementation can be beneficial here, again, just due to the decreased absorptive capacity of the digestive organs. Again, the three that would probably be worth considering first and foremost would be B12, calcium, and vitamin D. Again, these are going to go to support overall neurological functioning, cardiovascular health, and bone health. Definitely be cautious and talk with your healthcare provider about the supplement itself. Best to get a recommendation from the primary care provider. Again, we want to be mindful of taking any of these at a really high potency level, so a high concentration, because again, overconsumption of any of these can also be harmful. Fluid needs. So fluid needs are really important as we age, but the total recommendation basically remains the same for males and for females. We highlight fluid here though, just because as we age, again, with the decline in functioning of our different organ systems, older adults experience less thirst. They're still thirsty. Their body is technically still thirsty and needing hydration, but they're just going to sense that thirst mechanism less well. So it can be really worth maybe even writing out a fluid schedule for older adults, especially elder adults. Anyone who might be taking care of a very elderly person, definitely would be important to keep a fluid schedule and make sure that they're getting enough fluid throughout the day. Certainly older adults are at risk for chronic dehydration, where it's not just kind of an acute circumstance, it's an ongoing dehydration. So this can lead to hypernatremia, where there's a higher concentration of sodium in the blood. And of course, that can have adverse effects on heart functioning. And then, of course, a little bit about overweight and obesity in older adults and very elderly folks. So one of the issues here is that any of the diseases or disorders that we might experience in our older adult years are going to be exacerbated. The symptoms are going to be exacerbated with overweight and obesity. So at this stage in life, certainly still there's the risk of developing some of the chronic diseases we've discussed throughout this class, but even more so at this life stage, likely these chronic diseases would have already developed by now if they're going to, and so now we're sort of looking at the increased severity and consequences of these diseases. Of course, we're going to also see limited mobility with excess weight or obesity. Certainly that would lead to declines in like capacity to carry out daily activities, and naturally weight loss would improve, you know, this ability to carry out daily functions. Underweight in older adults, especially elder adults, is a significant problem too. We might remember in our discussions about malnutrition and undernutrition specifically that typically if we're undernourished, we're lacking protein. And if we're lacking protein, our immune system is not going to work as well. And this can be particularly dangerous for an older adult whose immune system is already probably on the decline just due to natural aging. So being underweight and, you know, a very elderly person, it can be quite dangerous. Would lead a person to greater susceptibility to diseases from virus or bacteria, and certainly if there were any sort of injury or broken bones, the ability to eat would be significantly impaired. So the treatment for underweight definitely depends on the circumstance. It can certainly be complex and it can certainly take time, just as we would see with an underweight adult. So best case scenario, again, it's person specific, but there might be support from a behavior specialist, medical professional, as well as psychological or therapeutic support. On the next slide, we have a little image of the 9 Ds, which are the 9 things that most commonly cause or lead to this weight loss in our very elderly population. Most of these, as we'll see, are related to lower caloric intake. So the 9 Ds are dementia. So dementia can lead to reduced caloric intake or you know, memory loss, even lack of understanding of a healthful diet. Drugs, certainly, and that can include prescription medication, dysphagia, that difficulty swallowing, dysgeusia, the loss in taste, dentition, so changes to the healthfulness of the teeth and the gums. Any of these are going to make eating or chewing or swallowing difficult or uncomfortable. Excessive diarrhea, right, that can lead to a lot of hydration loss and electrolyte loss. It can also just be uncomfortable and so might lead a person to not want to eat. Certainly depression can affect appetite and food choice. Again, disease, and again, loss of function or dysfunction of any part of the body, but in particular of the gastrointestinal system. So osteoporosis, this is a disorder, a disease that is pretty common as we age. In females, it's really diagnosed after menopause because of the change in estrogen levels. In males, when we see osteoporosis, it tends to be associated with, again, declining testosterone levels with aging, but potentially also related to steroid therapy and alcohol abuse. So osteoporosis, again, we took a look at this back in the bone health lecture. Osteo meaning bone and porosis meaning literally porous, so having like porous bones. And as the bones become more porous, they become more brittle and break easier. So the risk with osteoporosis is greater risk for hip fracture, especially in our older adult population. The ways to treat osteoporosis, and again, prevention throughout the lifespan, basically, but potentially supplementing with vitamin D and calcium, engaging in resistance training to support mineral deposition in the bones. And then arthritis, so this is that like painfulness in the joints. We have osteoarthritis and rheumatoid arthritis. So osteoarthritis is the one that typically comes about in aging, because it's usually just a disease of use, and sometimes it's called a disease of wear and tear. So again, it's an arthritis, kind of an inflammation and a degradation of the bones. So we see some of the tissue that's at the ends of bones that articulate with one another. So basically, the tissue in our joints starts to degrade, which can lead to, when those two bones need to articulate, the two bones grinding on one another. So it can cause a lot of pain in the joint. As always, some of the lifestyle things we can do to address osteoarthritis: get to a healthy weight if a person is overweight. Definitely include antioxidants and anti-inflammatory nutrients in the diet. Engage in water-based exercises to take some of the pressure off of the joints, but maintain physical activity as much as is possible. And then rheumatoid arthritis. So this is one that usually comes about more so in younger adults. It's not really associated with age, with the aging process at all. And then gout is an inflammatory arthritis characterized by these crystals that form in the joints. So specifically, they're uric acid crystals that form in the joints and cause that, a similar pain to osteoarthritis, but caused for different, the causes are different. Other current concerns that we see in our aging population, so constipation, again, that's coming about for a variety of reasons. The potential chronic dehydration, the potential change in diet or lack, again, any of the dysgeusia, the dysphagia, maybe the person's food intake has changed, and it's maybe not as healthy or robust. So ways to treat constipation: again, make sure to get adequate fluids, and include insoluble as well as soluble fibers. Dental health issues. So again, these can be just tooth decay. This can be like a gingivitis or a gum disease, or decaying of the gums. And again, these become particularly cautionary in our older adults and our elderly adults because it might lead to food avoidance. Vision disorders. So we see age-related macular degeneration and cataracts. Again, a healthful intake of antioxidants can help slow the effects or slow the onset of macular degeneration or cataracts. We also see cognitive impairment or dementia. And again, we would see a diet rich in antioxidants would help to slow the onset of dementia, as well as unsaturated fatty acids, which are the omega-3 fatty acids, are a type of unsaturated fat, which are another anti-inflammatory compound. And again, folate and B12, as well as B6 for healthy neurologic functioning, and as always, maintaining healthy weight. And then, depending on the scenario, pressure ulcers or bed sores, so especially for older adults or very elderly adults who are maybe in an assisted living home or a nursing home, who maybe aren't as physically capable or able as they used to be, and maybe require the support of an aide or a nurse to move them. Pressure ulcers can develop from like being in one position for an extended period of time, several hours, days, without being moved or rotated and taking the pressure off of that one particular part of the body. So certainly common on the backs of the legs, the buttocks, and the low back. And then medications. So definitely kind of a complex subject here in the aging population. There's this concept of polypharmacy. Again, just as the word would imply, poly meaning many, and pharmacy meaning pharmaceutical influences. So polypharmacy would imply that a person is taking more than 5 prescription medications at once. This is really not uncommon in our older adult and very elderly adult population, where they might have a list of 5, 10, 15 different prescription medications that they're taking. Any prescription medication comes with side effects, and then whenever we're taking multiple prescription medications, they may interact with each other in harmful ways. Oftentimes, many of the side effects are things that impair nutrient digestion and nutrient absorption. And depending on the type of medication, it may even cause us to, or cause the body to excrete excess amounts of the nutrient. So this is a challenge at any age in the life cycle, but certainly it becomes even more of an issue in the older adult and elderly population because of all of the and because of everything we've just talked about, the declining of the functioning of all the different organ systems. So nutrient supplementation can be certainly helpful, but my recommendation is always to really take a look and see, are there lifestyle changes that can be addressed to potentially reduce some of these medications so that maybe you can get the total number back down under 5. Because the nutrient supplement is sort of like one more, they're different obviously than medications, but at some level, they're still just this almost a band-aid rather than fixing the underlying cause. And of course, some medications we have to take them. We can't necessarily not. So again, talking with healthcare providers to see what's the best option for each individual. So this, I think, is a really helpful chart. I'm actually just going to back out of this mode for a second because, yeah, I cut off a little bit here. So let's see if that, okay, great. Yeah, so this is, I think, a really helpful chart. This is the one that I said that goes over drug-induced nutrient deficiencies or drug-nutrient interactions. So this is a short list, again, table 19.3 in your book. It won't necessarily test you on this, but I think this is just really helpful for anybody to have handy. Even if you like take a picture of this and keep it stored somewhere in your phone or on your computer, or if you keep your nutrition textbook throughout your lifetime, you can always refer back to it. So let's just take a look at a couple of ideas here. So antacids, right? So things that are going to block acid production in the stomach, maybe because of GERD or reflux. They might be prescribed for that reason. So again, any antacid is going to block acid production in the stomach. And what would be the result of that? It could impair the absorption of these 4 nutrients we talked about earlier when we talked about the atrophic gastritis. So any nutrients that actually depend on the acid in the stomach to be absorbed. So iron, calcium, folate, and B12. Let's see. Aspirin might actually reduce blood folate levels, and it might also increase loss of iron. So that's important to take note of. Again, taking aspirin maybe once, twice a year, not going to be a problem, but somebody who's taking aspirin every day probably wants to check on their folate and iron levels. Diuretics, also really common. So most diuretics, a lot of diuretics are going to increase loss of potassium, potentially also sodium, potentially also calcium and magnesium, which are 4 of our key electrolytes. What else? Laxatives, right? So if somebody's having constipation and suddenly they're on a laxative, that could increase excretion of dietary fat and fat-soluble vitamins, as well as some minerals. So no medication comes without side effects, and really very few, if any, medications come without nutrient-specific side effects. So antibiotics, I think, is another good one to highlight there, right? That's totally going to alter gut microbiome, even if only for a period of time. But depending on the length of use of the antibiotic, it may take some really hard intentional effort to recover a person's gut health after use of an antibiotic. So certainly going to reduce production of vitamin K, reduce the absorption of calcium, fat-soluble vitamins. It's going to reduce the production of those short-chain fatty acids by our healthy gut microbes, which support good immune health, which support our brain health, and support actually the overall functioning of the digestive cells of those enterocytes. So, yeah, anyway, just really important to pay attention to. Again, this is at any stage in life, but certainly the issues become much more pronounced as we get older. Some social concerns for older adult population. I'll start with the bottom two. So food insecurity and hunger. We just talked about this in Unit 4. More than 10 million older adults and very elderly are thought to be food insecure and or hungry in the United States. So again, this can come about from a variety of factors, a lot of which could be the same that we discussed in Unit 4. Could also just be in part related to social isolation. As a person gets older, maybe their social circle dwindles, maybe they, more and more family members or friends have passed away, and so maybe they have fewer people close to them to talk to. So that can certainly lead to increased risk for depression, which can lead to increased malnutrition. And then we also unfortunately see a fair amount of elder abuse that could be physical, sexual, emotional, or financial, and also elder neglect. And more often than not, this abuse or neglect is coming by a person who actually knows that elder person maybe well, or at least is in some sort of relationship with them. So that's a really important thing to look out for, especially anybody who's in the care of older folks or who has loved ones who are, older adults or in the elder adult population. Of course, abuse and neglect are important to look out for at any age too. And then lastly, so this is the last slide for the lecture. Just similar to how we talked about with children and adolescents, there are lots of community programs in place to try to address some of the nutrition-related concerns, especially food insecurity and hunger for the older adult population. Some of these are, well, I guess at least one of these we've already talked about, the SNAP program or the Supplemental Nutrition Assistance Program. So anybody at any point in life can apply to SNAP. They have to meet a certain income level, and then they get kind of food assistance, like financial food assistance. There are some farmers markets set up specifically for seniors. Sometimes they might set up, depending on the type, it might even set up at a senior living facility, making it really accessible. And of course, a farmers market hopefully is going to sell lots of fresh, usually local produce, and oftentimes healthy food, not always, but often. There's also a child and adult care program, so almost like an adult daycare, just to kind of engage older adults or elderly adults in some social activities or just, general activities, provide a healthy meal. The USDA has something called the Commodity Supplemental Food Program. So this is helping to provide older adults or very elderly adults with commodity food. So fruits, vegetables, meats, grain products, beans, usually in dry or storage form, so canned goods or dry goods. Something called the Nutrition Services Incentive Program. This is basically, again, a federal program that provides cash, like dollars, to different agencies that support home delivery nutrition services. There's the Emergency Food Assistance Program. So this is things like food banks, pantries, soup kitchens. The USDA, again, will provide different commodity foods directly to these programs, and then that food goes out to people in need. And then not strictly nutrition related, but just sort of care for elderly as they age. There's two types of end-of-life care. There's something called palliative care and something called hospice. So hospice is more general end-of-life care, and palliative care is typically when there's a disease or an illness. If it gets to a point where maybe it's so severe, the person or the family may choose to go on palliative care, which is basically just tending to this person really until they die, trying to make them as comfortable as possible, as pain-free as possible, but effectively discontinuing the treatment for whatever the illness or disease is. So with that, we have made it all the way to end of life, end of the life cycle, and then we have made it to the end of this class. So thank you all very much for taking the time to, sit through these online lectures. I know it's maybe not ideal, but I really appreciate your time and effort this semester. It's been fun getting to know some of you, albeit very virtually and very much just through email and through your writing. But I wish you all lots of luck in all of your finals. Definitely email me if you have any questions. I intend to put up a final review sheet, hopefully at least a week or 2 weeks even before the final, so you can take a look at it and use that to support your studies to review for the final exam. But yes, do email me with any questions as always, and good luck to all of you in all of your future endeavors. As always, I'll thumb through these review slides here so you can do a quick little chapter review. But thank you all for listening, and yeah, good luck.